Good morning, everyone. My name is Kenneth Paik. I'm a third-year medical student at UAB Heersink School of Medicine. Today, I'll be discussing a patient presentation that was presented in the emergency department titled Granulomatous Reaction and Tuberculosis Symptoms Induced by Bacillus-Calmette Murugan Immunotherapy Treatment. So this is today's agenda. We'll be talking about today's patient, as well as some background regarding BCG therapy, as well as some imaging studies and other examinations that were done for the patient following with the hospital course and treatment. So a 70-year-old man came to the ED for hematuria, fever, chills, nausea, vomiting, lightheadedness, confusion, and dry cough. A very unusual presentation. He was also hypoxic with an 83% of oxygen saturation. It was also feverish with a temperature of 103 degrees Fahrenheit. All other vital signs were normal, examinations were normal, chest and heart sounds were completely fine. Basic labs from the CBC and BNP were also normal. However, a key important information from the history was that he told us 3 weeks prior he received a standard dose of Bacillus-Calmette Guerin, otherwise known as BCG therapy, for his bladder cancer that he was diagnosed with earlier that year. So what is BCG? BCG is a vaccine from a live attenuated bacterial strain of Mycobacterium bovis, as you all may know, used as a prevention measure for tuberculosis. It was invented and discovered by these two scientists pictured on the right side, Drs. Albert Calmette and Camille Guerin, back in the 1921s. However, many years later, researchers determined that people who had bladder cancer, but also the BCG vaccine, had fewer recurrence rates than those who weren't diagnosed and received the BCG vaccine. This initially led to further studies, randomized controlled trials of using BCG immunotherapy as a way to treat bladder cancer, particularly in the 1970s, using randomized controlled trials. Scientists discovered that giving BCG injections were effective. However, directly inserting it into the bladder cavity was more a potent effect of immunotherapy. And immunotherapy essentially is stimulating our own body's immune system to attack the cancer cells. And in this case, luckily for our patient, bladder cell urothelium is particularly sensitive to BCG therapy. Not to go too deep into the mechanism of how we administer BCG, but essentially we insert a urinary catheter through the urethra into the bladder itself, fill the cavity with BCG solution, making sure that all parts of the primary tumor is covered by the solution. There are also suggestions to patients to move around, lay on the sides, lay on your back, lay on your stomach, to fulfill all parts of the cavity with the solution. We typically recommend patients to keep it for at least 2 hours before allowing them to void. And the standard treatment consists of these trials 3 to 5 times a week for at least 12 weeks, and then they're completely done with their trial. The pros of the vaccine for bladder cancer showed a reduction of mortality rates from 32% down to 14%. Fewer cystectomies were also performed. And at the 3-year follow-up, cancer deaths were reduced from 37 to 12%. However, there are side effects with this BCG vaccine that should not be undermined. These are associated with our immune system and patients who are immunocompromised, patients with autoimmune diseases, patients with comorbidities such as congestive heart failure, CKD, diabetes are also at risk of side effects. Further complications include systemic sepsis, hypersensitivity reactions, as seen in our patients discussed earlier, chills and fever, hypotension, and also multi-system organ failure. So going back to our patients, when he came to the emergency department, we immediately got a chest x-ray in which our radiologist determined to be reticular nodular disease bilaterally. By the clinical history, we did decide that the differential diagnosis included interstitial lung disease, potential metastatic disease as well as sarcoidosis. But most importantly, with the clinical history from the BCG treatment, we could not rule out hematogenous dissemination of BCG. The next day, he received a CT scan, which showed diffuse reticular nodular patterns as well as the X-ray from the day before. And the differential extended to potential miliary tuberculosis. Since this study did require some sort of correlation, we did follow up with other examinations. Blood cultures and sputum analysis were both negative. Other causes of granulomatous disease that we could think of, such as histoplasmosis and psittacosis, were also negative. Our last step was bronchoalveolar lavage, which was performed, which was negative for AFB and GMS stains, ruling out acid-fast organisms or other fungal or bacterial types of organisms. But strangely enough, the biopsy showed positive for non-necrotizing, non-caseating granulomas with inflammation on the right lobe. And essentially, you could see on the histology slide, this is what we saw. These multinucleated giant cells at the core of each center with lymphocytes surrounding it, thus being positive for granulomas. So the presence of these non-caseating granulomas on the biopsy does suggest some sort of mycobacterial infection and spread in our patient, given the clinical history. Hematogenous spread of Mycobacterium bovis could have potentially leaked into the bloodstream through inflamed, disrupted urothelium, whether that's from the catheter, a traumatic catheterization process, or from the tumor itself, we're not sure of. However, with this clinical situation and histopathology from our biopsy, I would like for us to take a second to think of what the potential diagnosis is. And our team decided that this was a disseminated form of BCG infection, given the clinical suspicion with the vaccine treatment. Immediately, the patient was given isoniazid, rifampin, and ethambutol. He had good response to medication, had a drop in his temperature below 100 degrees Fahrenheit. 3 days later, when symptoms were resolved, the patient was then discharged on the same medications for at least 6 months. He continued his management. Imaging studies did not show similar results, and he was completely cleared of his tuberculosis. And he continued surveillance of his bladder cancer, in which he continues to be negative for today. So for my conclusions, miliary tuberculosis after BCG immunotherapy are not common, but should also be concerning for particular patients like ours discussed today. And if discussed and diagnosed, we should treat it as early as possible to prevent mortality. And also, diagnosis of tuberculosis can be confirmed by the clinical studies and history that we gathered from the patient, as well as imagings of the lungs and the biopsies and the histological slides, which is the most important. And finally, a cautious selection of patients should be determined for BCG therapy. There should be some considerations such as autoimmune diseases, patients who are immunocompromised, patients with comorbid diseases like diabetes and heart failure should be considered in our patient population here in the South, so that dangerous complications as seen in our patient does not occur. Thank you very much, and I would accept any questions.
Hi, thank you for your talk. I was wondering, did you find other records of similar associations, or was this study just the one that you studied on?
So there was one study that had a patient that had a similar presentation in Europe, but other than that, this was the only patient that I've seen in the literature.
Okay, and because you ruled out any acid-fast organisms when you stayed, essentially you concluded that it's related to the BCG vaccine. But what like, I'm just not, I don't know, I'm not fully convinced that that's like, ultimately, you know, the correlation,
Right.
I guess.
Right.
And I'm just wondering, like, how was it conclusive for you?
So we definitely ruled out all other causes of granulomatous diseases. We also read in the literature that doing acid fast stains in the setting of disseminated vaccines has a low sensitivity rate. So even though the cultures were negative for acid fast staining, it doesn't completely rule out tuberculosis. However, the biopsy is the most important diagnosis in this case, which was positive for non-caseating granulomas.
Interesting, thank you.
Thank you.
How many years did this patient receive the vaccine before he came down with it?
So he received the vaccine treatment that same year that he was
Did he
diagnosed.
just started it?
He was towards the end of his course. Yeah. Towards I believe it was a 12-week course, and he was completing his last week when he experienced the symptoms.
So this may be difficult to answer just because it's so rare, but it's one thoughts are, I guess, is there any concern that maybe some of the gains that would have been made with the BCG treatment will kind of disappear in patients that have to get treated for this? And a follow-up question would be, if this did ever happen to somebody early in their course, I'm guessing that the BCG treatment for their bladder cancer would be kind of off the table as a continuing that therapy.
Right. So I think, as you mentioned, this is a rare complication of BCG therapy. So unless there are larger population settings in which this occurs in other patients, I don't see BCG therapy going away anytime soon, especially since it's such an effective method of immunotherapy for bladder cancer. I'm sorry, could you repeat your second question?
If this happened early in somebody's course, I'm assuming that probably you would say they would not be a good candidate to continue with BCG therapy.
Correct. So lucky enough for this patient, he was towards the end course of his treatment, which completely eradicated all the cancer cells. But correct, if this occurred earlier in the trial, then that would essentially cause the patient to stop the BCG therapy and find other methods to control the bladder cancer.
Thank you for that presentation. Did this patient have any risk factors for latent pulmonary tuberculosis?
Not that we could find in the chart. He was a 70-year-old man in the emergency department, so some forms of interstitial lung diseases could be possible as well. That could be a risk factor. Something that I didn't mention in the presentation was the patient was not a smoker, so not at risk for that either. But nothing in particular that we found, which is a very interesting case for this patient.
No military experience, time spent in prison, time in another country?
None of that, no, sir.
How would he have presented differently if his immunocompromised state with cancer and treatment thereof led to activation of pulmonary TB versus BCG dissemination?
So I believe that the presentation would be fairly similar. Looking at the biopsy and the histological slides, it would both show non-casing granulomas. Symptom severity would probably be different of BCG and tuberculosis. I do assume that patients who are diagnosed with tuberculosis itself and not from the BCG vaccine would present with more severe symptoms just from the pure exposure of the organism itself in the body. Whereas
Non-attenuated organism, you're saying?
Exactly,
Well,
yes.
and either way, the treatment would be the same.
The
So
treatment,
if
yes.
Whichever one you went with, your outcome would be good either way if you went with it. I was just curious if that had been entertained as a possibility.
Right. I think that's a very good thought. And based on the severity of the patient's symptoms that we discussed today, I would think that I'm not too sure. I haven't seen a patient diagnosed with tuberculosis yet in my training, But I would assume a patient with tuberculosis, not from the vaccine, would present with more severe symptoms.
You mentioned the spread of the BCG, how it disseminated, and whether it could have been catheter related or related to the tumor itself. Given that it was so late in this patient's course of treatment, how advanced was this tumor? Or was it resolving by this time?
So unfortunately, we didn't have any data on that from being a private practice urology clinic. However, assuming that the patient did not have any recurrences with bladder cancer despite having these symptoms in the emergency department, I would say that although traumatic catheterization may have been a role, the cancer itself was already on its way to be completely destroyed by the immunotherapy cells. So unfortunately, I'm not entirely sure how to answer that question.
Thank you.